Good morning, friends. Myself, Dr. Pankaj, and welcome to Pedia Academy by Dr. Pankaj. Today, we are starting the next chapter on Nelson-based series for upcoming NEET SS exam. This series will include previous year asked topics or the new additions in Nelson, which are likely to be asked. So, without further delay, let's start our next topic, that is demyelination disorders of central nervous system. Okay, this is a very important topic in neurology. It has been frequently asked. So, to start with basic structure of a neuron, which contains the myelin sheath. You very well know myelin is very important component of a neuron. If this myelin it is not formed since birth, this disorder is called as dysmyelinating disorder. It is genetically determined, as you can see, and leukodystrophy is one of the many examples of dysmyelinating this disorder. Again, next is demyelinating disorder. So this is, as you see, this is acquired, and this disorders disease in this disorder target normally form white matter. So by far you are clear. Dysmyelinating and demyelinating disorders, these are two terms. Okay, now we'll discuss acquired demyelinating syndromes. Okay, so what is the pathophysiology behind this? What happens? Immune-mediated injury occurs to myelin of brain, optic nerve, and spinal cord. Okay, antibody forms against these myelin subsets of neuron. Mostly these antibodies are IgG type, and two antibodies are very important, aquaporin 4 antibody and MOV antibodies. So we can what is aquaporin 4 antibodies? This is plasma membrane water transporting protein expressed in astrocytes and primarily involved in water movement, cell migration, neuroexcitation. So what we can see, this is plasma membrane water transporting protein. So this is aquaporin. Okay. Then MOG antibodies. These antibodies are exclusively expressed in CNS. Location in outermost laminae on the cell surface of oligodendrocytes make it available for antibody binding. So this is also very important. This is exclusively expressed in CNS, and location in outermost lamellae and cell surface of oligodendrocytes makes this available for antibody binding. Okay. Next, so this is actually a disease course of demyelinating disorders. This can be monophagic course and relapsing course. In monophagic course, as we can see, ADEM is there, optic neuritis and transverse myelitis. And in relapsing form, it is MS, MOG, multiple relapsing ADEM, MDEM, relapsing on aquaporin 4 and NMSOD spectrum disorders. So this is very important how they are classified. Mimics of demyelination. Okay, this is very important area because symptoms of demyelination can mimic some known demyelinating CNS or other system disorders. We'll see one by one. Migraine is one of them. Systemic rheumatological disorders can be seen like that. Mitochondrial disorders, primary CNS angiitis, infections, neoplasm, inherited white matter disorders, that is leukodystrophies, and primary CNS HLH syndrome. So these are mimics of demyelination. This is very important and potential area of MCQ. Now we'll discuss some disorders in brief. Okay, So what is ADEM? As we can see, ADEM is first polyfocal CNS event with presumed inflammatory cause encephalopathy present that cannot be explained by fever. So this is inflammatory origin and fever can't explain the encephalopathy. MRI showing T2 lesions of diffuse poorly demarcated T2 lesions. Okay. What is multiphagic ADEM? This is very important. New event of ADEM 3 months or more after initial event then can be associated with new or re-emerging clinical finding. So 3 month cutoff is very important. Next, multiple sclerosis. Okay, we'll just discuss MS in brief, not in detail. So, for definition purpose, multiple sclerosis can be uh, actually defined by if dissemination in time, that is DIT, plus dissemination in space, that is DIS, both should be present. Mark my words, both should be present. In dissemination time, one of the following is required. Okay, what are the four factor out of one out of four is required? That is simultaneous presence of MRI of one or more enhancing or non-enhancing lesions. Basically, first is MRI finding, second is CSF oligoclonal bands, and follow-up MRI from more than 30 days with one or more new enhanced or non-enhanced lesions, and 4 two or more acute episodes of typical MS, each lasting more than 24 hours or at least 30 days apart. So either one of this is required for a dissemination in time plus dissemination space. It should be more than of two site. It can be periventricular, juxtacortical, cortical, infratentorial. Mark my word, it is not supratentorial, it is infratentorial, and spinal cord. So this is multiple sclerosis definition. Just go through this slide again. This is very important. Has been asked multiple times. Neuromyelitis optica spectrum disorder. Okay, so this is actually NMO. If aquaporin 4 is present and aquaporin 4 is absent. If aquaporin 4 is present, one criteria is required, and aquaporin is absent, two criteria is required. Again, give your attention here. Just go through these criterias: optic neuritis, acute myelitis, area posterior syndrome, acute brainstem syndrome, narcolepsy, and symptomatic cerebral syndrome with MRI lesions. And if aquaporin is negative, two criteria are required. At least one core criteria must be optic neuritis and longitudinally extensive transverse myelitis or area posterna syndrome. So, the one criteria should be from these: optic neuritis, longitudinal extensive transverse myelitis, or area posterna syndrome. And second, dissemination in space more than two different core criteria, and third, exclusion of alternative diagnosis. So this is typical uh, actually definition of this NMO spectrum disorders. Just go through this slide once again and you will remember. Okay, so we'll just localize the things in demyelination. If it is involving deep gray thalamic and strial substance of brain, so what are the possibilities? It can be due to infections like EBV, JE, entero, and West Nile virus. It can be due to biotin responsive basal ganglia disease and gene is SLC19A3. This is previously asked question, is very important. Just mark it, is very important. And acute necrotizing encephalopathy is one more thing which can involve deep gray and thalamic and strial lesions. Next, multifocal white matter lesions. So this is multifocal. So you can see demyelination, ADEM, MS, and NMS and MOSD can do this. Autoantibodies, NMDR encephalitis can do this. Vasculitis, mitochondrial disease like LHON, and leukoencephalopathy and Charcot-Marie-Tooth disease. So this is very important slide, which are the DDs of multifocal white matter. Good morning, friends. Welcome to Pedia Academy by Dr. Pankaj, myself Dr. Pankaj, and we are here discussing this amazing series of Nelson-based pediatric PYT topics for NEET SS examination. And today's topic is ADEM, which is very important, has been frequently asked. So without further delay, let's go dive deep into the topic itself. So ADEM, acute disseminated encephalomyelitis definition is very important. It is inflammatory demyelinating event of early childhood presenting with acute onset polyfocal neurological deficit accompanied by encephalopathy and MRI changes consistent with demyelination. So the definition itself is very important. So I will just highlight the important things. This is inflammatory. This is demyelinating, occurs in early childhood, acute onset polyfocal event accompanied by encephalopathy or MRI changes consistent with demyelination. This is very important. Okay, the epidemiology of ADEM, it can occur at any age. Peak age is 5 to 8 years. Again, the previous year's question. Slight male predominance is there, and this is mostly monophagic, as we have seen. This is mostly monophagic. Okay, so if Adam first episode is there, so what can be the fate of next episode, or what we should tell to the parents ki Adam will, what will be next? Okay, so generally it is monophagic, and it actually doesn't recur. If recur more than 3 months, it is MDEM, okay, multiphagic Adam. If relapses there with optic neuritis, this is ADEM optic neuritis. If relapse is associated with the spinal cord, this is NMOSD disorder. So this slide is very important. Generally, monophagic disorders are associated with MOG antibodies in 50% cases, and RAS3 disorders are associated with MOG antibodies in almost 100% cases. So what are the basic physiology behind this? This is molecular mimicry with infections. So what are infections which can mimic, means which can produce ADEM? This is important question. EBV, CMV, varicella, enterobe, measles, mumps, rubella, herpes, mycoplasma, pneumonia, and COVID-19. Just go through this list. Okay, so clinical features of ADEM. In this encephalopathy is hallmark of ADEM. This is again a very important question, which is the hallmark feature of ADEM is encephalopathy. So initial symptoms are like non-specific: lethargy, fever, headache, vomiting, meningeal signs, seizures, and status epilepticus. Neurological symptoms are like visual loss, ataxia, motor sensory deficit, and cranial neuropathies. And concurrent spinal cord involvement, bladder bowel dysfunction may be seen, and it is rapidly progressive over days. Okay, neuroimaging. So this image has been multiple time asked. So you can see the patient, 6-year-old patient with ADEM, presenting with after mild infection and motor deficit. This is clinical spectrum, and this is showing T2 weighted MRI showing bilateral diffuse poorly demarcated lesions, gray matter involvement including thalamus and basal ganglia. This is neuroimaging of ADEM. Contrast plus minus, spinal cord plus minus, it can occur. And what is the description of these lesions is very important. These are large, sometimes confluent, bilateral, multifocal, edematous, mass-like tutu lesions of cerebral hemisphere, cerebellum and brainstem, deep gray matter structure, thalami, basal ganglia are often involved. And again, very important, after 3 to 12 months, complete resolution of lesions are seen ADEM. If it doesn't resolve, then it will be go to the spectrum of MDEM and the MS spectrum. Okay. Again, One variant which is important from this ADEM, this acute hemorrhagic leukoencephalopathy, this is Western Hurst disease. This is very important. Again, in the previous year's MCQ question. So, what is it? This is severe involvement in ADEM. These having large lesions on MRI, having mass effect, and polymorphonuclear pleocytosis in CSF. In later slides, we'll see ADEM has lymphocytosis in CSF, but this disease is having polymorphonuclear pleocytosis in CSF. Okay. Lab features generally CSF is normal in ADEM, pleocytic lymphocytosis is seen, CSF proteins are raised. EEG is generalized slowing of encephalopathy like origin. Focal, it is demyelinating ADEM. Then what are the DDs? So DDs are very broad. So treatment should be started as empirical, antiviral plus infective workup. If MRI after 3 to 12 months, no improvement or new lesions are seen as we discussed, we should consider MS, antibody-associated disorders, leukodystrophy, tumor, vasculitis, mitochondrial metabolic and rheumatological disorders. Basically, we have to think of alternative diagnosis. So, what is the treatment of ADEM? So, this is again important slide. Methylprednisolone is given 20 to 30 milligram per kg per day for 5 days. Again, important, maximum dose is 1 gram, followed by oral prednisolone 1 to 2 milligram per kg per day for 4 to 6 weeks. Again, maximum is 40 to 60 milligram per day. So, this dosing of methylprednisolone is very important. For refractory cases, IVIG 2 gram per kg over 2 to 5 days and plasmapheresis sometime needed 5 to 7 exchange every other day. So this is the ADEM for you. So we have discussed ADEM in detail, and this is next lecture on this amazing Nelson based previous year's topic series for NEET SS. Stay tuned for these type of lectures. Do like, share and subscribe this channel. We will be covering almost every aspect of previously asked topics in this series. Till then, we'll meet you in next video of this series.